welcome. Today we're going to be doing a little reflex test on the gastrocnemius soleus complex, or the Achilles tendon. And then afterwards we're going to discuss about the motor neuron and how it occurs. So I hope you enjoy. Alright, we're going to be testing reflexes of the Achilles tendon. So I have the patient in prone, foot slightly off of the plinth or table. I'm going to apply a little gentle dorsiflexion to allow it to actually contract and feel it a little bit better. I'm going to strike the Achilles tendon right above the insertion on the calcaneus. And I can actually feel it move up against my hand a little bit, just like that. So in the clinic I would do both sides just to make sure that the actual reflex is normal, and it's actually moving right around there. So that's it. That's reflexes of the Achilles tendon. As you see with a normal reflex, there's a slight movement of the foot. This is because with the reflex test, it's a quick phasic stretch from the tap of the reflex hammer onto that tendon, which activates neural contraction between the muscle spindle and alpha motor neurons to the same muscle. So by tapping that tendon, it gives it a quick stretch. The muscle spindle and the muscle itself is embedded parallel to the muscle fiber, causes a contraction. So you have 1A fibers going back to the dorsal horn, coming back, or synapsing, coming back out on the ventral horn and causing the contraction of the gastroc, which moves the foot into plantar flexion. Next, I will perform a spasticity test for elbow flexors. So we're going to be checking spasticity of the elbow flexors, the biceps brachii, the brachioradialis, and what we're going to be checking on first is how he looks. Usually you'd have him standing up in the normal anatomical position. You want to make sure that the arm's at its side. Little tone in there, but not a lot. If it's just flopping around, it's hyporeactive as far as spasticity. Then what you want to do is move on to a passive movement. So I'm going to put a little bolster here just to give it a little bit more room here. And you want to keep a little bit of contact here. Not a whole lot of sensory input because it might change the test. But relax, sir. All we're going to do is just move him forward and back. Before that, though, what you'd want to do is actually palpate or touch the bicep. Make sure there's no tight areas or anything like that, because that could also elicit spasticity. So palpate, then you're going to move it in through slow passive range of motion. Spasticity is a velocity dependent type of deal. So the faster you start moving it, the more spasticity in an abnormal person. In a normal person, even if it's fast or slow, it should be a fluid motion. So even quick stretches. So the test is not going into flexion, but actually into extension, because that's where the stretch is being elicited onto the bicep. So now on the Ashworth scale, that would actually be a 2 because it has normal spasticity or normal reflexiveness to it. Let's talk a little bit about what goes on at the neural level. So this is actually a part of the rubrospinal tract, which starts in the red nucleus of the midbrain. It decussates immediately at that level of the midbrain and then descends to the lower motor neurons in the C-spine and upper thoracic spine cords area. Its main function is to control upper limb flexion, which that would make sense because if there was a lesion on this tract, then you wouldn't be able to control that flexion, which would cause spasticity in the velocity of the moving of the arm into extension. So in a normal person, they can control that, which allows it to stretch and without any rebound to it.